So let's get into a discussion now of the radial nerve. The radial nerve derives from the posterior chords. And recall that the posterior chord is the single unified chord comprised of the posterior divisions of the superior, middle, and inferior trunks. So this is a large nerve, and it's composed of contributions from C5, C6, C7, C8, and then inconstant contribution from T1, but occasional contribution. And before the radial nerve becomes identified as the terminal branch of the posterior cord sends off a branch which is the axillary nerve. And so the axillary nerve then goes to serve the muscles of the scapula and the deltoid, and that cord then continues as the large radial nerve. So we're going to get now into discussion of entrapment neuropathies of the radial nerve. And as the radial nerve comes down and out of the axilla, it traverses in front of, well, it comes through the axilla and then traverses behind the humerus at about the mid-shaft level of the humerus, sends off some cutaneous branches known as the posterior brachial cutaneous nerve and the inferior lateral brachial cutaneous nerve, and it continues down the humerus through the radial spiral groove. And then at just above the elbow, the radial nerve comes around the lateral aspect of the elbow and superficial and anterior to the lateral epicondyle of the humerus. From there, it pierces through the supinator muscle to give rise to the posterior interosseous nerve, and it also sends a superficial branch deep to the brachioradialis muscle. The superficial branch continues down into the hand as the dorsal digital nerves, whereas the posterior interosseous nerve, as it pierces the supinator muscle, gives off muscular branches to the extensor pollicis brevis and also the extensor pollicis longus muscles, as well as branches to the abductor pollicis longus muscles. Okay, so that's the distribution and course of the radial nerve from the posterior cord all the way down to the tips of the fingers. Now, as I said, the radial nerve is comprised of contributions from the nerve roots of C5 through C8. The C5 contribution to the radial nerve serves primarily the brachioradialis muscle. So the brachioradialis muscle is involved with forearm flexion, with the wrist in a neutral position. The C6 portion of the radial nerve goes to both the supinator and brachioradialis muscles. The supinator is involved with forearm supination, and the brachioradialis, as I said, is involved with forearm flexion with the wrist in neutral position. When the wrist is in a supinated position, forearm flexion is accomplished by the biceps and brachialis muscles primarily. The C7 portion, the largest contribution to the radial nerve, innervates the tricep muscles, also the extensor carpi radialis longus muscles, the extensor carpi ulnaris muscles, and those muscles contribute to elbow extension, wrist extension, and also for the extensor carpi ulnaris wrist extension. So you can remember radial nerve and C7 is involved with both forearm and wrist extension. The radial nerve is the extensor muscle, and the C7 nerve root is the extensor nerve root. The C8 portion of the radial nerve innervates the extensor digitorum communis muscles, the extensor indicis muscles, and then also the extensor pollicis longus and brevis muscles. And so that makes the C8 nerve root, the C8 contribution to the radial nerve, is responsible for extension of all fingers, including the thumb through the EPL and EPB. So really, you can think of the radial nerve as elbow, wrist, and finger extensors. And the radial nerve sends off some branches both above and below the elbow. And these are the locations where the radial nerve can become trapped. Now, above the elbow, the radial nerve sends off a branch to the brachioradialis, and this is largely a branch comprised of fibers from the C6 nerve root. So this is where, when we begin to start to see a nerve root lesion at C6, for example, with a herniated disc at C6, C7, or C5, C6, then we start to see some loss of function of the brachioradialis muscle. We start to notice some weakness in elbow flexion when the hand is in a mid-pronated position. It also sends off a branch to the anconeus muscle. The anconeus muscle is involved with elbow extension in combination with the tricep muscle. Also sends off, this is above the elbow, sends off a branch to a motor branch to the extensor carpi radialis, which is largely a C7 muscle. And the extensor carpi radialis, if you could isolate it in isolation from the extensor carpi ulnaris, you would see that the extensor carpi radialis longus is involved with radial wrist extension, with extension of the wrist from the radial aspect, or we could even say with extension of the wrist with radial deviation of the wrist. So it has a combined vector that splits the angle between wrist extension and radial deviation, and we refer to that as radial wrist extension. So those are all potential muscles that could be affected with a radial nerve entrapment above the elbow. And as the radial nerve continues below the elbow, it gives off a branch known as the posterior interosseous nerve. Also, some textbooks refer to it as the deep branch of the radial nerve. And the posterior interosseous nerve serves many muscles, all of which are involved with extension of either the wrist, the fingers, or of the thumb. So, for example, muscles supplied by the posterior interosseous nerve include the extensor carpi radialis brevis, not the longest, that branch comes off above the elbow, but the extensor carpi radialis brevis is served by the posterior interosseous nerve, the extensor digitorum communis, extensor digiti minimi, extensor carpi ulnaris, the abductor pollicis longus, extensor pollicis longus, extensor pollicis brevis, and extensor indicis proprius. All of those are involved with wrist extension, finger extension, and or thumb extension. And you'll note that the radial nerve, by way of the posterior interosseous nerve, serves extension of all fingers. All fingers. The thumb being extended by the extensor pollicis longus and brevis, the index finger being extended by both the extensor indicis proprius and the extensor digitorum communis, the middle ring and index finger being extended by the extensor digitorum communis, and then the pinky finger being extended by both the extensor digiti minimi and the extensor digitorum communis. So quite a broad distribution of the radial nerve, all on the backside of the forearm and on the backside of the wrist onto the backside of the fingers. And you can really think of the radial nerve as the extensor nerve of the forearm, wrist, fingers, and thumb. Now, continuing to follow the radial nerve down the forearm, we note that below the nerve but above the wrist, the radial nerve gives off a sensory branch known as the superficial radial nerve. And there are dorsal sensory branches that provide for sensation, and these are the sensory distributions now of the radial nerve that supply the skin area over the central proximal surface of the palm. So that's quite interesting that the dorsal sensory branches provide for sensation around to the palmar aspect of the hand in the center of the palm. And then continuing down, the radial nerve then sends off branches below the wrist. Now below the wrist sends off three main sensory branches. The first one goes to the first web space, and we're talking about dorsal web spaces here. Goes to the first dorsal web space. There's a branch to the second dorsal web space. There's a branch to the third dorsal web space. So let's think about these one by one, and you might even look at the dorsum of your hand here and take a look at the dorsum of the first web space. Here, the sensory branch provides for sensation first to the web space, and then also to the dorsal surface of both sides of the thumb. That's both the radial and ulnar sides of the thumb, and then also the radial side, which is the thumb side, of the index finger. The second sensory branch provides for sensation to the second web space, the dorsal surface of the second web space, and then also the ulnar side of the index finger and the radial side of the middle finger. And then the third sensory branch provides for sensation to the third dorsal web space, and then also the ulnar surface of the middle finger, and then also the radial surface of the ring finger. Well, on the dorsum of the hand, that only leaves the fourth web space and the ulnar ring finger, and then the radial and ulnar surfaces of the pinky finger, and we'll see later on that those areas are served by the ulnar nerve. Okay, so almost the entirety of the dorsum of the hand, including both surfaces of the thumb, and all the dorsal aspects of the index and the middle finger, and then the radial aspect of the ring finger, all served by the radial nerve. So that's actually fairly easy to remember, especially when it comes time to do sensory testing for the radial nerve. And the AMA guides provide us with an excellent diagram to demonstrate the distribution of the radial nerve, and this is on page 487 for those of you that are following along. And if you are following along, I want you to take a close look at the picture of the radial nerve as it's depicted here in the AMA guides. And for those of you that aren't looking at this image, either in your book or on this PowerPoint presentation, I want to point out a couple of interesting facts about this image, and the AMA guides do a good job. You'll notice at the top of the diagram it shows the nerve root contributions that contribute to the radial nerve. And you can see that they're showing a definite contributions from C5, C6, C7, C8, and then on T1 they used a dashed line, and that's used to indicate an inconstant or occasional contribution of the T1 nerve root to the radial nerve. So I find that interesting, and they repeat that model with all of the peripheral nerves, and we'll talk about the median and ulnar nerves here as we go. So the AMA guides describe branches coming off of the radial nerve. They describe 4 branches that come off of the radial nerve above the elbow. There are branches to the 3 heads of the tricep muscles. Those come off the radial nerve approximately at the upper to mid shaft of the humerus. Slightly lower down, there's motor branches to the brachioradialis muscles. Still slightly lower down, still are branches to both the extensor carpi radialis longus, and then finally a branch to the anconeus muscle. Then below the elbow, as the nerve has given off its motor branches to muscles high in the forearm, it sends off a major motor branch known as the posterior interosseous nerve. And that's indicated in the AMA guides by a dashed line with an arrow. And the posterior interosseous nerve is a motor nerve, sending long axons from the ventral horn of the spinal cord, anterior horn cells, and sending off motor branches to the extensor carpi radialis brevis, the supinator muscle, and the extensor muscles of all the fingers, including the extensor digiti minimi, extensor digiti communis, and the extensor indicis proprius. Also sends off motor branches to the thumb muscles, including the abductor pollicis longus, extensor pollicis longus, and also to the extensor pollicis brevis. So, as we said, all of the extensor muscles of the forearm, wrist, and all fingers. Okay, so as you look at this diagram, or as you imagine it in your mind, what would be some potential sites of compression or irritation of the radial nerve along this course? Well, above the elbow, there are not many sites where the radial nerve commonly does get compressed and or irritated. We're going to see that most of the radial nerve compression syndromes take place at or below the elbow. But there are a couple of interesting compression neuropathies that take place above the elbow, probably the most frequent of which takes place in the axilla or in the high medial aspect of the upper arm. In the axilla, the radial nerve can become compressed through improper use of crutches, wherein the patient takes the whole weight of their body on the axilla. Now, up in the axilla, the radial nerve has now just come off of the posterior cord of the brachial plexus, and it's a large branch that has yet to give off any sensory or motor branches. And so with crutch palsy, we're going to find the entirety of the radial nerve throughout its entire distribution can possibly be affected. In some cases, and some references state that sensory symptoms associated with crutch palsy are rare, while motor symptoms do predominate. But again, in the event of a moderate or severe injury or severe compression of the radial nerve due to crutches, the entirety of the radial nerve can be involved, and so we would see sensory and motor symptoms all the way down to the tips of the thumb and all fingers, as we previously described. Next, the radial nerve can become compressed in the high medial aspect of the arm, and this is the famous Saturday night palsy that we learned about back in medical and or chiropractic or osteopathic school, wherein a person has a few too many drinks and falls asleep with his arms hanging over the back of a park bench, where the medial aspect of the upper arm is compressed against the hard wood or concrete of a park bench, thereby creating a compression and ischemia of the radial nerve. Now, in this area, generally the radial nerve has already given off its muscular branches to the three heads of the tricep muscles, or at least to the long head of the tricep muscles, and so the tricep muscles are generally spared with a Saturday night palsy. However, we could or would see symptoms down into the forearm and hand, including weakness of the extensor muscles of the forearm and the hand. And we'll talk a little bit more about some of the symptoms that you would expect with compressions at the various sites. Occasionally, you can have a radial nerve compression due to fractures of the midshaft of the humerus, because the radial nerve travels down through the backside of the midshaft of the humerus in the radial spiral groove, and the nerve can be inflamed, compressed, and or irritated with a direct blow or fracture of the midshaft of the humerus. Again, like Saturday night palsy, in this situation we would see sparing of the tricep muscles, because at this location the radial nerve has already given off its muscular branches to the triceps. However, all other radial nerve functions could be affected. And then finally, in the radial spiral groove in the back of the humerus, there is a superficial. The nerve becomes superficial, and there's not much muscular covering over the radial spiral groove. So, with a direct blow or a fracture in the humerus in this area, we could also see irritation or compression of the radial nerve, and it would present similarly to a fracture of the midshaft of the humerus, in that the tricep muscles would be spared, but all other functions of the radial nerve, because of this high location, this high level of injury, all other functions could be affected, including both sensory and motor losses. Now, below the elbow, we're going to find the most common sites of compression of the radial nerve, and there's 4 potential locations where the radial nerve can become entrapped below the elbow. Now, remember that below the elbow we've already given off branches to the brachioradialis. We've already given off branches to the triceps. We've already given off branches to the extensor carpi radialis longus, already given off branches to the anconeus muscles, so it's not likely that those muscles would be affected. We're now talking about locations below the elbow. So four potential sites of entrapment below the elbow. The first is the arcade of Froese. We'll talk about what the arcade of Froese is. That's F-R-O-H-S-E. The radial nerve can become compressed in fibrous bands anterior to the radial head. The radial nerve can be trapped amongst a fan-shaped grouping or arcade of vessels comprising the radial recurrent artery, where there's this confluence of blood vessels. And then finally, it can become compressed over the tendinous edge of the extensor carpi radialis longus muscle. So let's go over these one by one. The arcade of Froese is a fibrous arch over the posterior interosseous nerve at the superior border of the supinator muscle, where the posterior interosseous nerve comes around the lateral posterior aspect of the humerus bone. It comes just anterior to the lateral epicondyle of the humerus, and then dives down the lateral aspect of the forearm just adjacent to the radial head. And immediately adjacent to the radial head, it divides into two branches. One is the posterior interosseous nerve, and then the second is the superficial branch. And where the posterior interosseous branch dives underneath the supinator muscle, it can get trapped or inflamed or irritated there due to repetitive or heavy action of the supinator muscle. For example, with unaccustomed or heavy use of a screwdriver or other twisting movements of the forearm, both in resisted supination and also in resisted pronation. That would be both concentric and eccentric contractions of the supinator muscle can cause aggravation of the posterior interosseous nerve as it passes underneath this fibrous border or fibrous arch right there at the origin of the supinator muscle, right adjacent to the radial head. Below the supinator muscle and immediately anterior to the radial head, there are fibrous bands due to the confluence of muscles in this area, and with either hypertrophy of muscles and or thickening of fibrous bands can cause compression of the radial nerve here. In this case, we could have either compression on either the posterior interosseous nerve, or depending upon the location of the fibrous bands, could compress either or the superficial branch. Immediately medial to this area, there's a fan shape of vessels as the brachial artery comes down the anterior aspect of the humerus bone. As it gets immediately adjacent to the medial aspect of the of the radial head, it divides into both the radial and the ulnar arteries. And at this point, just slightly inferior to the radial head, the radial artery gives off a small branch known as the radial recurrent artery. And what the radial recurrent artery does is it projects blood flow back up the humerus, and it anastomoses with other collateral and recurrent branches. And so there's this arcade of vessels that takes up space and forms a broad fan-shaped structure in the same area as the supinator muscle and in the same area as the fibrous bands. And so with either anomalous development or compression over this area, this is another sensitive location where the radial nerve can become compressed. Now, the radial recurrent artery passes immediately anterior to the radial head, and the radial nerve passes over the radial recurrent artery, but underneath the radial artery. So the radial nerve here is sort of threaded over the top of the radial recurrent artery, but underneath the parent vessel of the radial artery. So there's a tortuous angle that the radial nerve has to traverse, and this is also a common site of compression and or irritation. Finally, a little bit further down, over the tendinous edge of both the extensor carpi radialis and extensor carpi radialis longus and brevis muscles, there is a tendinous edge similar to the fibrous edge of the supinator muscle, and this is an area, a fourth area, where the radial nerve can become compressed. So depending upon the location where the radial nerve is compressed, we're going to get a different constellation of motor and or sensory symptoms. So let's discuss those now. Now, with deficits of function of the radial nerve, we're going to have deficits, both motor deficits and sensory deficits, and we're also going to have some autonomic deficits, or it is possible to have autonomic deficits. So let's talk about the motor deficits. Well, you can really remember the radial nerve as the extensor nerve. It's the extensor nerve of the forearm, the wrist, and the fingers. So with a high radial nerve lesion, way high, like up in the axilla, the triceps muscles can be affected, and we're going to have loss of elbow extension. Now, if we have a high radial nerve lesion, we could also have loss of extension of all the other muscles served by the radial nerve, such as at the wrist, such as at the finger, such as at the thumb. But as the lesion starts to come lower and lower down the humerus, and even down and below the elbow and into the wrist, the upper muscles would be spared. So with a low lesion, forearm extension would be preserved, meaning that the tricep muscles would be preserved. But also deficit of motor function of the radial nerve would involve losses or weakness of wrist extension, and that's both radial and ulnar wrist extension due to involvement of the extensor carpi ulnaris and also the extensor carpi radialis, longus, and brevis. We're going to have weakness of elbow flexion of a semi-pronated forearm. And what muscle does that sound like? Weakness of. Loss of flexion or weakness of flexion of a semi-pronated forearm. That would be weakness of the brachioradialis. We're going to have weakness in resisted supination. Now, there are two muscles that supinate the forearm. One is the biceps. That's served by the musculocutaneous nerve. So forearm supination will be preserved, but due to loss of function of the supinator muscle, which is served by the radial nerve, forearm supination would be weakened. We're going to have loss of finger extension of the proximal phalanges, especially of the index finger, and especially of the thumb due to weakness of the extensor indicis proprius, and then also the extensor pollicis longus and brevis. So, working backwards up this list, you want to start thinking, if I found a weakness, for example, if I had weakness of index finger and thumb extension, where would the most likely location for the lesion be? Well, it would be down low in the forearm, wrist, and or hand. If I had weakness of forearm supination but preservation of forearm flexion of a semi-pronated forearm, where would the lesion be? Well, it would be right around at the radial head, probably at the arcade of Froese. Okay, so whenever you find a weakness, you have to think to yourself, okay, where's the most likely level of the lesion? Okay, with sensory symptoms, sensory deficit of the radial nerve, we're going to have pain and burning along the anterolateral arm. Anterolateral arm. So this is an anatomic position. Picture the anterolateral arm, or even reach one hand over and touch the anterolateral arm. That's on the lateral aspect of the bicep, the lateral aspect of the humerus, and the lateral aspect of the tricep muscle. Also, we're going to have pain and burning and numbness and tingling on the lateral aspect of the forearm. And we're going to have possibly aching, numbness, tingling, and even sometimes total loss of some sensation, even though that's rare, over the dorsum of the first, second, and or third web spaces, and the dorsal aspects of the thumb, index, middle, and radial aspect of the ring finger. Now, what about autonomic losses? What kind of autonomic losses can you suppose we could suffer as a result of a deficit of function of the radial nerve? Well, the autonomic functions of the radial nerve are not really well known. In other words, it's not known, and I haven't been able to locate any references which indicate that the radial nerve serves particular glands or serves particular blood vessels in the upper extremity. But according to Hilton's law, we can probably make a couple of suppositions. And that is, Hilton's law states that the bones and joints are probably served through autonomic branches of the same nerve that innervates muscles that moves the joint or bone. And let me say that again. Hilton's law states that joints, the innervation of joints is not well mapped out and is not well established. But it's generally assumed that joints are innervated by the same nerve as the muscles that move that joint. So in this case, we assume that the radial nerve probably gives articular branches to the posterior aspect of the elbow, because the muscles that move the posterior aspect of the elbow, such as the supinator and such as the tricep and such as the extensor carpi radialis longus and brevis, and the extensor carpi ulnaris, and all those muscles that contribute to the movement of the elbow at the posterior aspect, those are all served by the radial nerve. And by extension, we could assume that through analogy to Hilton's law, sensory areas where there are glands and blood vessels, and where those sensory areas are served by the radial nerve, probably the glands and vessels also receive contribution through autonomic fibers transported in that same nerve, the radial nerve. So we might expect to see autonomic dysfunction in the dermatome distribution of the radial nerve. So the dermatome distribution is along the anterolateral arm, the lateral aspect of the forearm, and then the dorsal aspect of the hand. So what kind of autonomic findings could you expect? Well, findings of vascular loss, such as Raynaud's findings, such as blanching of the skin, hyperemia of the skin, mottling of the skin, cyanosis, signs of cyanosis, clubbing of the fingernails, those are on the dorsum of the fingers, sweating, hyperhydration, all would be consistent with dysfunction of the radial nerve by analogy to Hilton's law. Okay, so let's review the main features and findings of radial nerve lesions, and then we'll go on to discussion of the ulnar and median nerves. Now, radial nerve lesions can generally be subdivided into two basic locations. We can have a high radial nerve lesion, or we can have a low radial nerve lesion. And with high radial nerve lesions, for example, an entrapment in the axilla, or in the upper or even the midshaft of the humerus, the so-called high lesion, on physical exam we're going to see paralysis of all extensors of the wrist and the digits, including the thumb. And we're going to see paralysis of forearm supinators. Now, depending upon the location of the lesion, very high lesions, or lesions very proximal in the humerus, may also affect the triceps. Recall that the motor branches to the triceps leave the radial nerve very high, just as the nerve exits the axilla. But lesions below the midshaft of the humerus would probably spare the triceps, so elbow extension would be unaffected. Now, on the sensory side, with high lesions, we're going to have numbness on the dorsal radial aspect of the hand and on the dorsal aspect of the radial 3.5 digits, especially over the first web space. And you can remember the first web space, and you should remember the first web space as the autonomous zone for the radial nerve. The AMA guides describe this area, this circular area over the dorsum of the first web space, as the autonomous zone for the radial nerve, which indicates that it's an area exclusively supplied by the radial nerve. Other references use the term pure patch, which is also a descriptive term to indicate that this area over the dorsum of the first web space is purely radial nerve. So that is the most likely location with a radial nerve lesion where your examinee will report sensory symptoms, especially numbness. And the reason for this distribution of pain and this distribution of loss of motor function is because high lesions, high radial nerve lesions, affect the nerve prior to its bifurcation into motor and sensory nerves, motor and sensory branches. Recall that the motor branch is the posterior interosseous nerve, and the sensory branch is the superficial radial nerves. And so with high lesions, we're going to find both motor and sensory findings. And with lower lesions, depending upon where the lesion is, we could have motor and or sensory findings, or we could have purely motor findings only, or we could have purely sensory findings only, depending upon which portion, whether it be the posterior interosseous nerve or the superficial radial nerve, depending upon which of those two are trapped, will determine the type of symptoms that we'll have. Generally, lesions lower down, like at the radial head and just below the elbow, in the area of the radial tunnel. And we talked about 4 different types of entrapments in the radial tunnel. On physical exam, you're going to find pain and tenderness to palpation over the anterolateral proximal forearm in the region of the radial head and neck. So I want you to look down at your own forearm, look at your left forearm, and put your forearm in anatomic position. If you place the index finger of your right hand on the lateral epicondyle of your humerus, of your left humerus, you'll find on physical exam that the maximum tenderness associated with the radial nerve entrapment in the radial tunnel will be about 4 finger breadths below the lateral epicondyle. And sometimes this can be confused with pain associated with lateral epicondylitis, but with lateral epicondylitis, the pain will be directly over the lateral epicondyle, and pain with radial nerve lesion will be about 2 to 3 inches below the lateral epicondyle. Also, with compression of the radial nerve in the radial tunnel, you'll find that symptoms would be intensified by extending the elbow and pronating the forearm. Pronating the forearm causes a stretch on the supinator muscle and will compress the radial nerve as it dives underneath the supinator muscle. And in addition, resisted active supination and extension of the long finger will also cause compression of the radial nerve, either as it dives underneath the supinator muscle, or as it passes between the heads of the extensor carpi radialis longus and extensor carpi radialis brevis muscles. Okay, so those are some physical examination findings common that you would find with radial nerve lesions. Let's now go on to a discussion of the ulnar nerve.